Okay, hello, welcome, dear listeners. This is Limit Children's Hospital monthly webinar broadcasting live today again on 16th of May. We want to start by sincerely appreciating every participant and special thanks to those who joined us in our just concluded 4th Abuja Perinatal Symposium. We will continue our academic sessions today. We are the Limit Hospitals.
The Limit Hospital is a designated specialty hospital for pediatrics, neonatology, and adolescent medicine. It draws on the rich experience of healthcare provision and the corporate patient-centered work ethic that differentiates and characterizes every Limit Hospital service center.
Yeah, so the hospital was founded in the year 1982. Our focus has consistently evolved while we maintain focus while we evolve, we maintain focus on quality care precision, and patient-centered care specialty for all. And the Limit Children's Hospital is an integral part of this mandate. So Limit Hospitals, there's a Limit Multi-Specialty Hospital, there's a Limit Children's Hospital, there's a Limit Cardiac Care Hospital. Yeah, so today we are dealing with the topic systemic arterial hypertension in children. It may interest some people. Why didn't we just say hypertension in children? And if we say hypertension in children, it bothers some people. Do children actually have hypertension? You see? So it is systemic arterial hypertension. I am Dr. Igoche Peter, and with me today is
Giorbari, Pop-Yornwin.
all right, good. So just like joking around this topic, we have the hypertension people know about. We talk about that. But there is also pulmonary hypertension. I think what pulmonary hypertension day was celebrated last week. Yeah, and then there's also ocular hypertension, which is PUMA. There's also portal hypertension. So you see, if we just say hypertension and we do not specify, then we're actually like playing football without
So by the end of this webinar, you'll be able to answer the following questions: how to measure blood pressure in children, how do we define systemic hypertension in children, what are the values and how do we go about it, what are the causes of systemic hypertension in children. We'll also be looking at the components of diagnostic workup for systemic hypertension in children, getting to the causes and how to manage systemic hypertension in children.
All right, so talking about the definition of hypertension, we know that we have adult fixed values, right? And one thing that distinguishes pediatrics is that we have values for different ages. So I see that as one of the most fascinating things in pediatrics. Right? So that's why the objective is really, really important. The definition of hypertension in children, right? So whereas the adults we see normal blood pressure is fixed at 120 millimeters of mercury. For pediatrics, it's not like that, right? So a given value of blood pressure may be normal in one child, but abnormal in the other child. In fact, it could be normal at this age, normal in the other age, normal for this gender, normal for the other gender. That makes pediatrics dynamic. Yeah. Okay, so we have methods of measuring blood pressure. I mean, I know we are all aware of upper arm auscultation, right? Now, to set records straight, this forms the basis for the discussion of today, because all the references we are going to use, the reference established normative values are based on auscultation, right? Have you seen where people use measure blood pressure on the wrist? Okay, interesting. So there are some electronic devices that exist that people use to measure blood pressure from the wrist. I believe that for adults, Because there's a concept of peripheral amplification of systolic blood pressure, where the radial blood pressure is higher than brachial, right, in children, because the fact that their vessels are still very elastic, very pulsatile. So for children, we would get an unusually higher blood pressure from the radial artery. So we want to discourage wrist blood pressure measurements in pediatrics. We also have ambulatory blood pressure measurements, right? What about ambulatory?
Okay. This has been advocated for because it seems that it gives a more accurate representation of the blood pressure compared to those measured in clinic or blood facilities. We'll see later on, I'm going to be discussing white coat hypertension, which is a very popular phenomenon. So an ambulatory blood pressure gives us the blood pressure measurement in casual settings when child is not anxious and in their normal setting. So that is going to give a more representative and accurate value.
So we have this situation where we see children who have come to the hospital before and they've gone for full blood counts, they will traumatize them, getting blood sample. Right from the car park, the child starts crying. So the next time they are coming to the hospital, the child is aware that this part of the town, there's a building where children will receive needle pricks. So imagine you have to take blood pressure from that person who is already anxious. Right? Yeah. So it's used to confirm, also to confirm blood hypertension in children greater than 5 years. So it's ambulatory. So the device is attached to the child. So you can imagine attaching something for him to a child less than 5 years. I mean, the child
was like very
will know it. Yeah. So it's found that if you compare ambulatory blood pressure measurements and casual brachial arterial measurements, there is a better correlation between the ambulatory blood pressure measurement values with left ventricular hypertrophy.
Another method of measuring blood pressure, which is quite common these days, using automated devices. This method has actually been discouraged because there is no setting standard. Different devices, different manufacturers have different standards, and there is there's no research concerning what blood pressure should be using these devices.
Yeah. So actually, you see, how does it sound? So I get I don't want to mention the product. I'm not marketing for you. So I get a brand of electronic device XYZ trademark, and I'm using it brand new with the battery that I inserted today, and my colleague is measuring with the same kind of device that has been used for the last 3 years, and the battery there has lasted for 3 weeks, right? They will very likely get very different readings. Now, we leave it for adults, but in pediatrics, because we work with normative values, right? We do not have any reliable standard to interpret the values we get. So automated devices are largely discouraged. So at best, yes. So someone who used the auscultatory method, the mercury zoom manometer, to make the diagnosis, or will use ambulatory blood pressure monitoring to get there. Because the person will follow up 24 readings can be gotten, but then it will never replace mercury. Good. So the question is, how frequent should we begin measurement of blood pressure? When we know that pediatrics is a very, very wide age range, right?
So currently, it's advocated that measurement of blood pressure should start by 3 years of age.
Yeah.
Usually, otherwise healthy children, no condition.
Yeah.
So, and this should be measured annually after, if there is no other indication to. But however, for children who are obese, who have renal diseases, diabetes, or our medications are going to increase blood pressure, and should have anti-asthmatics and so on. So then we'll have more frequent at each encounter, which clinic visits measure that children at the age of 3. Also, there are children where which start measuring this pressure before the age of 3, because there's an increased risk of those children having hypertension or developing hypertension earlier than other children, such as the children who are born premature.
So you know that as technology increases, we have better incubator care. We have people who are doing a lot of specialty. like in Limit Children's Hospital, taking care of current baby of the baby that's 24 weeks, right? 0.5 kg, no, not 0, 500 grams. So they said, don't say 0.5 kg, say 500 grams, give some value to it, right? So now, these babies are less than 2 years. I mean, they are small for gestational age. They are extremely low weight, even very, very. Yeah, for these ones. So by the time we discharge that baby is coming up for follow-up at any time. If you are seeing that child at 3 months, 6 months, that child should have blood pressure measure. For that kind of a child, you don't wait till 3 years. Yeah. And babies who have had history of for congenital heart diseases, it is important to measure as early as possible. We know that congenital heart disease, whether regarded, congenital heart diseases can occur in isolation or in association with other congenital anomalies. Yeah. So that we made the echo for this child, like the 2 echoes we just did before this presentation. Now, VSD, both VSD. Now, we always have to check for position of VSD, right? So there's an anomaly, the vascular anomaly. If we have recurrent UTIs in children, even if they are below, they are supposed to hematuria, proteinuria, or any membrane disease in the individual or in the family. Yeah. So it's interesting to know that sickle cell disease, tuberous sclerosis, those systemic disease should have blood pressure monitored really, really earlier than the general population. So the question we have for ourselves and our listeners today, how frequent do we measure blood pressure? And how young age do we start measuring? Well, these are the standards. Right.
So, how do we define hypertension in children? So, as we've stated earlier in our introduction, hypertension in children does not have a general range. So, it's statistical. Empirical researches have been done. So, hypertension in children is based on age and gender.
Yes.
So, according to the 5th report of the American Association of Pediatrics,
what we previously known
what we previously known as pre-hypertension now being replaced with elevated blood pressure, and we'll see what values that is as we go on in this way. So, and it's also been advocated that a diagnosis of hypertension should not be made until we've gotten a blood pressure greater than 95th percentile on 3 or more separate visits over a period of time.
Yeah, so even if it's 1 week apart, right? Somebody will ask over separate visits.
Yes, 3 different clinic visits.
It's okay. Yeah, so definition of blood pressure definitions and categories from the various stages. Men looking at this slide here, we have towards the right side, maybe from your own end, children aged less than 13 years and children greater than or equal to 13 years. So we're already seeing that we don't have a single value for elevated blood pressure or the stages of hypertension. In pediatrics generally, blood pressure that is normal is below the 90th centile for age and gender, looking at children between 1 to 13 years. Right? So, but we said by the time it's above or equal to the 90th centile, right? It's already elevated. Above 90th centile is elevated. But if it is less than the 95th centile, right, then it's elevated blood pressure. So less than 90 normal, between 90 95 elevated. Now, any child at all with 120 over 80 millimeters of mercury is elevated. So you see, the normal adult value is a problem in pediatrics. So anything between 120 over 80 millimeters of mercury to less than the 95th centile. Now, all these centiles we are talking about, you will have them. There is a chart. You will have them as we progress, right? So if we have between 120 80 to less than the 95th, whichever one is lower, then it's elevated. Now, stage 1 versus stage 2. For stage 1, greater than 95th, less than. Yeah, so the lower range here is greater than or equal to 95th. The upper range here is 95th plus 12 millimeters mercury. Never mind the
Check.
the charts that we'll see will explain them. So if we have any child that is between 1 to 13 years, whose blood pressure is now more than 120, right? So 130, 80, 139, 89. Whether you are using any of these, that's this one here, or the percentile values range here is stage 1 hypertension. But it's greater than 95th centile to plus 12 milligram to greater than of it is elevated, is stage 2 hypertension. But children who are greater than or equal to 13 years, they now have values that approximate the adult values, right?
Although here, any value greater than 80 is already elevated. That's only blood pressure. Greater than 80 is already elevated blood pressure. So we expect less than 80 for that.
Yes.
Less than 120.
Less than, yes. So by the time any child, let's say 14 years, with 128, that's already elevated. So if this is not clear, we shall illustrate with good. So these are blood pressure. We deliberately put these charts here, knowing that you will get the slides at the end of the presentation. So we'll walk us through these charts, this percentile chart, so that it becomes easy. Let's take, for example, these are blood pressure levels for boys. So there's a different chart for girls, and then for boys by age and height percentile. So we are saying it automatically means if I have to measure the blood pressure of a child in the consulting room or what, I must measure the height also. So these are the difference between pediatrics and adults. So we rely so much on the height. So let's take randomly a child that is 7 years old. So me, I'm used to measuring in centimeters. So randomly, let's just say that child is 120. Cool. 120, the height is 120. You see, in centimeters, it's 120, 121. So, but this is the nearest. So track it up. This child is at the 25th percentile for height. 25th percentile for height, 120. So whatever the blood pressure is, we are going to across this line. Yes. So if that child's blood pressure, say, is 120, that blood pressure is 120. No. We already say that if it's 120, so let's say 118. If it's 118, look closely. We have 111 here. So 118 is actually between the 95th centile and the 95th plus 12 millimeters mercury. So that is the so that's already hypertension. So we said less than 90th centile is normal. Between 90 and 95 is pre-hypertension. So between 95 and the 95 plus is stage 1. So above that. So this child has a stage 1. Now this is for systolic blood pressure. Then this side, because the height was at the 25th centile, we also interpret the diastolic that way. So let's see. So this is just here for us. These boys, 8 years to 14 years. Still boys, 15 to good. So then girls, good. Yeah. So we have a child in here. How do we measure the blood pressure? Yeah, they are going with it.
So the first thing to do before measuring blood pressure is to ensure that the child is seated properly. We'll see that later on. Basically, sit with the back supported, legs uncrossed, and the child should have rested for about 2 to 3 minutes prior to taking the blood pressure. So blood pressure measurement can be done by auscultation or by oscillometry. Oscillometry is usually applicated for children less than 3, less than equal to 5 years. So after measurement, have our charts standby. Should have that in a consulting room clinic. So if the child's blood pressure is greater than or equal to the 90th percentile, the answer is yes. Then we'll have to measure the blood pressure twice and then get an average of the two values. Then that's the average that we'll take to classify if the child has elevated blood pressure, stage 1 hypertension, stage 2 hypertension. So if the average is greater than the 90th percentile, would consider, because the measurement may be also method of oscillometric measure. Earlier when we stated, we said this whole webinar is based on oscillatory measure. Even the charts we have are based on oscillatory. Because the oscillatory measure gives a different blood pressure reading. So
it has its own chart.
Yes, it has its own chart. So based on this chart, if what was done was not on oscillatory, we have to repeat the blood pressure measurement twice again using the oscillatory, and then getting the average of that. So if the average is greater than 90th percentile, we can then classify the child based on stage 1, stage 2, stage 3. However, if it's less than, after doing all this, then the child has a normal blood pressure.
Yeah. All right. So let's do just this slide on some small academics. So blood pressure concept. So if you have a coin, you have two sides, right? And the two sides of a coin of blood pressure alteration from because of the variability, we have the white coat phenomenon and the accommodation effect. So what's white?
White coat phenomenon, I think a lot of people will be familiar with it. So it's when the blood pressure reading in clinical setting, in hospitals and clinic, is greater than what you get outside clinical setting, at home, at school, basically anything outside a health facility.
Yeah.
And it's usually related to anxiety and these other scoliosis, which give a temporary increase in blood pressure. Previously, this was thought to be benign, but recent research has shown that it's not as benign as it used to be.
Yeah, it's important for us to know not to just consider them hypertensive, and not to just consider them as disregard as normotensive, right? So it's not as benign. So it's considered in the class of elevated blood pressure. And once it's elevated, it requires follow-up. And then it's important to track it outside the clinical setting. Yeah. So a nurse in the school clinic who is skilled with auscultatory, not the very easy
Measurement.
Yeah, good. So school measured daily blood pressure for 3 to 4 weeks, or we get average of 2 or 3 readings, taking the morning, night, morning. Or better still, 24 ambulatory blood pressure, where the child is in a normal state. Yeah.
So the opposite phenomenon to the white coat, we mentioned two sides of the coin, is the accommodation effect. This is not widely known.
Mm-hmm.
So this is like when we have a reduction in blood pressure with each clinic visit.
Yeah.
So imagine a child comes in, maybe the first clinic visit, because of anxiety and everything, blood pressure is elevated. At the next clinic visit, it is lower than what you
Yeah, child is acclimatizing to
used to the environment. It's not as careless, you know. So this is what's called the accommodation.
All right, so we want to classify hypertension based on etiology. Generally, we have two types. The essential, not essential because it has to occur, but it's just there because there's no identifiable cause, right? So then there is a secondary hypertension where we can identify the cause. And for some of them, we can actually treat and cure, right? So it's important that for every child we see with hypertension, it should be in our hands. Is this actually essential hypertension? So we say the diagnosis of exclusion, you've excluded other identifiable causes. So the causes could be renal, like a glomerulonephritis, which could be acute or chronic. Pyelonephritis, means clinicians should form the habit of doing renal and root tenderness, right? When the child is having urinary tract symptoms. Obstructive uropathy, like in boys with posterior urethral vascular hypertension or renal vein thrombosis. For the cardiovascular, coarctation of aorta will cause elevated blood pressure the older the child gets, right? And then it's also found in patent ductus arteriosus or aortic insufficiency. Now, some other causes, endocrine causes, hyperthyroidism, everything is hyper.
Yeah.
For them, everything is hyper. And then catecholamine excess, like chromocytoma or neuroblastoma. Yeah, so other things, even drugs. So we like to discourage the use of NSAIDs, and anybody who's on NSAIDs, NSAIDs are usually nephrotoxic. So it could go through the nephrotoxic pathway to eventually lead to elevated temperature. Now, interestingly, sympathomimetric drugs, I will not mention the name of the drug because I'm not marketing nor demarketing any product, nor discouraging. So, but we use these drugs with caution. So we have some star drugs, right? Some cough medicines, theophylline, used with caution because they could cause secondary hypertension. Yeah. So
How do we evaluate a child comes with hypertension? So we're looking at it based on the presenting complaint history, physical examination, which include both blood pressure measurements and examining generalized or every other system. So we've seen there are different causes of hypertension, secondary hypertension, and also by performing investigations, general and specific, and lead us to the diagnosis of exact cause.
yeah. Okay, so presenting complaint. So we say presenting complaint, but depends on the severity of the hypertension. Because we said there's normal blood pressure, there's elevated blood pressure, there's stage 1, there's stage 2. But there's something we're not really going to talk about in this presentation, hypertensive emergencies. That will be handled in subsequent webinars, right? When we say hypertension is mild, right, we're talking of elevated blood pressure or even stage 1, right? They're usually asymptomatic. Now, so how do you manage something that is without symptoms, right? So that means clinicians should be aware that as from the age of 3 years, every child should have blood pressure measured once and then annually thereafter. And then when we have those risk factors, we measure them more frequently. And then if we have some of those special class of children, like those who are born preterm, we measure earlier, right? So this one is a complaint that is not voiced out, that the clinician picks out. But if the hypertension is an acute step, it may be symptomatic at presentation, right? At this point, blood pressure is elevated, and they are not talking of some urgency or emergency symptoms. So in patients who have glomerulonephritis, when they start having headache, dizziness, nausea, vomiting, irritability, I mean, that is a presenting complaint, right? So other complaints could be neurological manifestations like stroke. So the diagnosis of stroke, if it's coming at the first time, should make the clinician consider blood pressure profile, what it has been, congestive heart failure, same way, or renal dysfunction. Now, these are end organ pathology. So it's actually taking us towards secondary hypertension or hypertension polymannic that now costs, right? Because a child who has essential hypertension, poorly treated, can get into congestive heart failure. Okay. So history. Now in history, there are different types of history. History of presenting complaint, which will log into the presenting. But the review of system is part of history. Medication history is part of it. Social history and family history, right? So if we review the system, so realize that blood pressure is negative. Was there history of congenital heart disease at any point? Whether it's present or surgery has been done for it, it's important that that history is distributed. Now, history of obstructive uropathies, urinary tract infection, renal surgeries. People who have stones removed, renal stones removed, we should get those history. Yeah.
So as we've seen earlier, that certain medications that we use frequently can cause elevated blood pressure and hypertension. So it's good to have a very good drug history. So take note of any use of corticosteroid, anti-asthmatic drugs in children, cold medications, as we mentioned, common nasal drugs, aminoglycosides, and then cocaine use, especially in adolescents.
Yeah, substance. They call it poop. Substance. Right.
Very important to also have a good medication history. Not glossarides when taking history. Also, social history can. There are a lot of people that take coffee these days, so be able to assess how much of coffee or tea someone is taking. It also into taking blood pressure measurements and cause of the hypertension. It's very important to take a family history, so non-family history, a lot of genetics and play these conditions. So any history of essential hypertension in the family, any cardiac disease or stroke.
Yeah. They are still on the social history. Talk about adolescents, that's where lifestyle is being formed.
Yeah.
So lifestyle practices like smoking, excessive alcohol intake, sedentary lifestyle, all those things are social history that are necessary to take. Good. So the almighty blood pressure. So please fasten your seatbelts. We spend a lot of time talking about the nitty-gritty of blood pressure, measurement because that is the main thing. So how do we measure blood?
So as we stated earlier when we discussed the algorithm of blood pressure measurement, so the first thing is to ensure that the child has been rested for some time, usually 3 to 5 minutes. I mentioned points with hypertension and more anxiety that can lead to transient elevated blood pressure.
Yeah.
So the child should be quiet for 3 to 5 minutes, back unsupported and feet uncrossed. The feet uncrossed has been proven because there's research that has done that shows that if the temporary crossing of legs leads to some contractions in the muscles, and this can transiently elevate blood pressure. So it's very important. So all these tiny details actually can give a false vibe that means the child is hypertension when there is no. Also, it's very important to measure on the right arm. I know there's a lot of misinformation of measuring on the left arm most times. But if we go through our anatomy, we see that the first branch of the trunk is usually right subclavian.
So if you see from the heart, from the left ventricular foot tract, the aortic is mostly ascending aorta, the arc of the aorta. So the first branch actually the right subclavian artery. So that right subclavian artery is nearest to the heart. So and then as you go through the arc of the aorta, you now have the left. Good. So sorry, the first one is brachiocephalic trunk. Brachiocephalic trunk branches to right subclavian and then the internal common parotid. So we don't have any fear about coarctation at that point because it's as you go distally towards the junction of the arc of the aorta and aorta where you have the common parotid, right, and the left subclavian. At that point, a jugular ductal, there will be a coarctation. So if you are measuring blood pressure where on the left, right, the coarctation at that point may affect. So you get falsely different elevated values here. So the value from the right is more for consistency and the chart. Okay.
So as we seen earlier, it's recommended to take an average of at least 2 measurements and get 2 different measurements and take the average. That is more accurate than taking one blood pressure measurement, classifying the child based on what we get.
So this is a recommendation of the National High Blood Pressure Education Program and the American Heart Association. So you have to do that. Blood pressure is measured with the arm at the heart level, supported and covered. So you cannot have somebody putting on long sleeve and then just put the long sleeve or politely just let the person remove the long sleeve. The person is not talking and gisting while they are taking blood pressure. So how do we measure blood pressure? We auscultate with the bell of the stethoscope. Now, this is going to cause a lot of controversy and a lot of questions, but we stand current with established evidence and we can explain it. Now, if you look at the screen here, you have the diaphragm of the stethoscope for high frequency sounds and the bell of the stethoscope for low frequency sounds. So first of all, the correct sounds we are hearing, are they actually high frequency sounds? So if you answer that, you don't have any problem with what part. So it's the bell of the stethoscope. So next time you find a doctor using the diaphragm to measure, you laugh. The doctor did not join webinar. Tell them to join webinar. Good. So it's the bell of the stethoscope. Placed on the brachial artery. So there must be palpation to identify the brachial artery in the antecubital fossa. Right. So the lower end of the cuff is like 2 to 3 centimeters above the cubital fossa. This is because you want space to place the stethoscope, right? So you inflate the cuff. So you would have done radial palpation. So there's the palpatory method to get. So when you get it, you inflate 20 to 30 millimeters of mercury above that point. That then deflate slowly at the rate of 2 to 3 millimeters. So when you find people deflate so fast, you wonder what they are checking, right? So systolic blood pressure is the first corrective sound here, while the diastolic blood pressure is the 5th corrective sound we hear. Now, this 5th corrective sound is a recommendation of National High Blood Pressure Education, right? If the sound, occasionally we hear sounds continuously until 0. In that case, we use the sound where it muffles at the 4th sound. Okay, So measurement of blood pressure in childhood. Now, pediatrics again is different from adult medicine, right? So here we are specific about the size of the bladder width and the bladder length, right? So we said peculiarities for pediatric blood pressure. As we said, one, we must take the height.
Yeah.
If you are to measure the blood pressure, we need to see that you have a tape measure in your clinic where you get the midpoint between the acromion and the ligament midpoint. So that's where it's been taken. So at that midpoint, we get the circumference. We realize that the bladder width should at least 40% of it. Yeah, so 40 to 50%, right? The length can be taken to 80 to 100. But most important, bladder width of 40%. Okay, good. So we are switching the game to four extremity blood pressure measurement.
Okay. So for extremity blood pressure measurement is where we measure the blood pressure both in the arms and the leg. This is very important to rule out coagulation of water. Mention is very important cause of secondary hypertension in children. So earlier
So by the way, is it optional?
is it
Optional.
No, it's not.
It's mandatory.
Yeah.
So if we ever make a diagnosis of hypertension in child, we should have done a fourth extremity. Else we are doing village practice. All right, fine. This is because coagulation of water is very common.
Yeah.
It's very common. I mean, when you talk about the being common, I mean secondary hypertension, yeah, renovascular as coagulation as the commonest. So, right, and it's something you can treat and get a cure. So you have to exclude it, right?
As we mentioned earlier, there's a peripheral amplification of blood pressure. So the farther away measurement is from the central point of the heart, we expect that the blood pressure should be higher.
Yeah.
What it is. So in for extremity blood pressure, what we're expecting is a higher blood pressure in the lower limbs compared to what we're getting in the upper limbs. So usually we place the child in the supine position for blood pressure measurement. We're using a larger cuff this time around for the lower limbs.
Very true. So in pediatrics, again, we cannot have one size fits all. We cannot have one size fits all. Because I wouldn't imagine that the appropriate cuff that has a bladder weight of 40% for arm is what is used for the thigh. Because my thigh is bigger than my arm, right? So very, very good. So just like we place a bell of the stethoscope along the brachial artery in the tibial fossa, for lower extremity measurements is on the popliteal fossa over the popliteal artery. So the question we're asking is how many of us have that? Okay, so this is to explain lower extremity blood pressure determination. The patient is in supine position, and the knee flexed into, and then the diaphragm. Now, this stethoscope, this picture is like cartoon, right? But it should be the best. Okay.
So I've stated the time blood pressure, we're expecting it to be greater or equal to the arm value, except in because we have more. Especially like we explain the concept of the peripheral amplification of systemic blood pressure.
Yeah.
As you go further away,
yes, it increases.
So if we have a systemic blood pressure that is less than what we get.
Okay, sorry, again, because of this concept of peripheral amplification, is why we discourage measurements of wrist blood pressure in pediatrics. Now, when we leave that, we will not touch the adults. They can continue with wrist blood pressure measurement because for adults, the vessels are no longer as elastic as it is in pediatrics, right? So, issue of peripheral amplification may not be so much of a problem with adult blood pressure measurements, but it's a big deal in pediatrics. Yeah. So, systolic blood pressure in the legs usually 10 to 20% higher. Yes.
Yeah, anything less than that, we're suspecting a condition.
Yes. So if we have that, if it's reversed, and if we have a lower blood pressure, then possibly even a condition. So you see, you can make it a little palpitation of aorta or examination without it. So you do it to make your conclusion Then without telling the person doing the echo, just go. If the person does the echo with another result, that person didn't go to school. All right, so blood pressure in units and small children. Yeah. So we talked about pop sounds, they are low frequency sounds, and they're even weaker in infants, so in units and small children. So auscultatory normative values, they exist, but they are not reliable. So we talk about oscillometric method. So this is another method of measuring blood pressure, and is preferred in units and in children. So this table here gives us the range of normative blood pressure using the Dynamo monitor. That's an oscillometric device for less than or equal to 5 days. So we say between 1 to 3 days, we have the mean value of 50, right? Yeah. So this is 90th percentile, 90th percentile and 95th percentile. Yeah. Okay. Good diagnostic workup.
So in aiding our diagnosis of the exact cause of blood pressure, it's very important. So every part of our examination is important, right from the general examination. There are things that we see that can tilt us to certain conditions, such as obesity is a very common cause of essential hypertension. It's a very treatable cause.
Yes.
So say a child a BMI that's greater than 50%, you should be thinking of this child will most likely have elevated blood pressure.
Yeah.
You have to do that.
Yeah, so because you mentioned BMI, and we're talking of diagnostic workup examination. BMI, we need the weight. So in the general examination, it must be clearly stated what the height of the child is, what the weight of the child is, so that we can classify overweight, obesity, and classes of obesity. Yes.
So in other children who might have hypertension from adrenocortical disorders, they may also be obese. You can see something like striding and other things that we see in adrenocortical disorders too. And it's important to know that children with secondary hypertension from renal disease are rarely obese. So if we're seeing a child that's not obese and we're having an elevated blood pressure, just start thinking of other things.
Yeah, the renal.
Other things apart from renal that may be the cause.
All right, so pulse. So we'll check the pulse. So we've talked about general examination, using height, weight. Yeah. So check the pulse. Pulse will be found in latent ductus arteriosus or aortic regurgitation. Now the pulses will be weak or absent at the femoral level. So we have weak or absent femoral pulses, and we have the difference in arm versus leg blood pressure. We think about coagulation. So in children, normally systolic blood pressure is higher, right, than the normal. But if there is a difference from that, it's reversed. You know that systolic lower limb has higher because of peripheral amplification. Systolic blood pressure. Good. So investigations. All patients, all children. So it's not only when a child say he has a painful micturition that we do urinalysis. Yeah. So urinalysis, electrolytes, urea creatinine, lipid profile, whether fasting or not, right? And then every child that is less than 6 years should have, or those with abnormal urinalysis, yeah, ultrasonography, so that we can rule out the venovascular cause. Yeah.
So children who are obese, it's important to take glycated hemoglobin. As we know that there could be an increase in insulin rates in obesity, and it could be a risk of also them getting diabetes too. So to rule out diabetes too, important to take glycated hemoglobin so we can get the root cause of the hypertension.
Yeah.
Also, it's important to screen for liver enzymes, check for increased elevated liver enzymes, AST and ALT, to do a fasting lipid panel on children with dyslipidemia.
Yeah, okay, fine. So we have other tests see there. Good. So there are some specialized investigations that we need to do. So if a child has hypertension, it's good to do echocardiography to rule out or maybe diagnosis for a patient of PH. So at echocardiography, we check at the suprasternal view, where we can clearly outline the ascending aorta, aorta, and descending aorta. At the the point where the aorta is descending, we find some constriction. So it depends on the severity. But any constriction, narrowing, you really evaluate more closely of the aorta. Now, so that coarctation of the aorta would cause hypertension, right? Now, echocardiography to make that diagnosis. Echocardiography also to follow up children who are hypertensive from any other cause, right? So they could have left ventricular hypertension. You are not talking about target organ damage, right? Left ventricular hypertrophy following hypertension. So how do we make the diagnosis of left ventricular? Now, the M-mode echocardiography display with the machine will calculate its own, will give a left ventricular mass of greater than 25 gram per, 51 gram per meter, then raised to about 2.7, whether boys or girls. But if the left ventricular mass values based on body surface area becomes different for boys and becomes different for girls. So we've checked the left ventricular geometry, left ventricular wall, relative wall thickness, also check ejection fraction. So by the time the heart is hypertrophied, pressure is more dilated, starts beginning to have a left ventricular systolic dysfunction, right? So every child who has hypertension should have echo repeated 6 to 12 month intervals. So we can monitor these parameters. So other specialized
well, in imaging for vascular diseases, as we know that secondary renal disease is a very important cause of secondary hypertension. So it's important to do a Doppler renal ultrasound, especially in normal weight children when are bigger than 8. Also to assess the vascular nature of the renal vessels, do a CT angiography or an MRI angiography. Other specialized tests, especially when we're looking at adrenocortical diseases, have a high renin or low renin hypertension. So it's very important to measure plasma renin activity. To be elevated in hypertension, which is related to high renin output, and have a low renin hypertension, excess neurocortical effects.
Okay. So other specialized chemistry. So we talked about plasma renin activity. Now, to also talk about aldosterone in urine and blood, then to far urine catecholamines, and also to far free cortisol. So as we have it slide, right? So management, we are making progress in this discussion. So management of essential hypertension. Good. Management is for essential hypertension and for secondary hypertension. So we are discussing essential hypertension management at this point, and the treatment will be pharmacological or non-pharmacological. So non-pharmacological is what we start with, commonly speaking. We will give indications for drug therapy, so we are not saying we must be, right? But conventionally, we start with these non-pharmacological, which are basically lifestyle. So counseling on weight reduction, because there's a specific amount of weight that is lost and correlating with the drop in blood pressure, right? So healthy diet, we shall see in the next few slides what we mean by healthy diet, regular aerobic exercise, and avoidance of smoking. Avoidance. So in lifestyle interventions, we are targeting smoking cessation, while we are talking about reduction in alcohol. Okay, so DASH diet recommendation. DASH is actually dietary approach to stopping hypertension. Now, you see that the management of hypertension in very good centers, it should be multidisciplinary. So the pediatrician or doctor seeing the child, working hand in hand with the dietitian, right? So this is clearly said. So fruits, vegetables should be high in the servings, also whole grains, right? So if we're going to take meal, then low fat. Now, fish, poultry, lean red meat, less than to reduce, right? Added sugar. Yes, added sugar. So taking Capri-Sun. Okay, please, I'm not against anybody's business, right? Good. So, but we reduce added sugar. And then dietary, so you got salt intake. No, sorry, we are moving forward. Good. So drug therapy.
So when do we consider the use of drug in essential hypertension? There are various indications for the use of drug. One is when non-pharmacological approaches are tried, but they are not effective.
At least for 6 months.
Yes, reduction of blood pressure. Also, when we have severe systematic hypertension, in this case, we don't even wait at the initial presentation. We're trying to reduce
hypertensive emergencies, use intravenous.
So, you mentioned persistent hypertension, despite lifestyle modification, we're having that medication to start on antihypertensive. We have any hypertension at all that is symptomatic? You mentioned them.
When the child has acute glomerulonephritis, having headache, vomiting, dizziness, right? We should start.
So if there's any stage 2 hypertension without a modified factor, there's no factor you can say you can do this and reduce any modification. So the medication to also start.
So see this now. We have an asymptomatic stage 2 hypertension without. So if there's stage 2 asymptomatic hypertension and the child is obese, you want to see if that child can lose weight, and that's non-pharmacology.
So any hypertension with target organ damage, when we're saying left ventricular hypertrophy, or if there's any family history of any complications, hypertension, to start treatment early to prevent those complications from arising.
So drug of choice. We know that choosing the drugs, because antihypertensives is a topic, is a whole encyclopedia, right? So, but let's just narrow it down to three classes of drugs commonly. So, angiotensin converting enzyme inhibitors are good initiating therapy, right? Angiotensin receptor blockers, long-acting calcium channel blockers. Well, thiazide diuretics mentioned hydrocortisone. Just let's keep that in my head, right? So African American children, Negroids, they have less receptors for the angiotensin converting. So if the response will higher dose. So drug doses in children have a range. So if we choose that angiotensin receptor, we need to use higher. So we can consider calcium channel blockers. So if the child has hypertension with chronic kidney disease, proteinuria, remember we said urinalysis is an essential general. So if it is with proteinuria or DM, AC inhibitors or ARBs are good, right? Because they are renal protecting. We shall see some more specifications. They are renal protecting. If the child is overweight and use of melatonin, so AC inhibitors, ARB, calcium channel. We want to avoid diuretics and beta because it can increase blood glucose level. Good. So what are the dosages now for this? We do not say break the tablet, all right? So we have deliberately put a screenshot from the recommendation of the PIP report of the drugs. So you will see that we have a coding for age, right? Initial dose, maximum dose, dosage interval, and the formulation. So let's take, for example, Arterial can be used in infants, right? So less than 1. If we are using for a child less than 1, then 0.05 milligram per kg. If we're using for a child of 6 years old, we're using 0.5. So those are the differences, right? Let's say lisinopril cannot be used for a 3-year-old, right? So this table is important so that we have it beside us. So we have the ARBs, the thiazide diuretics, as we have here. So calcium channel blockers, the dosages are also. We know that amlodipine is quite common, and we can use it from 1 to 5 years. Right? Okay, so this table was just put in. It's not something we are going to discuss, just for our listeners to have it because this is for severe hypertension, and we shall have another webinar where we will discuss severe hypertension, hypertensive urgencies and emergencies. Right. So what are the goals of treatment?
For a child with uncomplicated primary hypertension without any end organ damage, say left ventricular atrophy, or maybe same proteinuria and urinary, the goal is to reduce the blood pressure to less than the 50%. So basically reduce it to to elevated blood pressure. Yes. While in children where we have a CKD, diabetes, all this evidence of end organ damage, the goal is to reduce it to normal, which is less than the 90th percentile. So different in global treatment.
Yeah, so in some cases, we may need to step down or cease therapy. Now, in counseling children, this always comes. So, as many hypertensive children have treated, they are caring for, this always comes up, especially the adolescents, right? Are we going to step down one day? Are we going to cease this therapy one day? Good. Let's say that in selected patients, those who are overweight and have successfully lost weight, right? It's possible that we could step down and the blood pressure reduce, especially those who are on. Yeah, it's still possible. But there must be follow-up. Good. So when we follow up, we are also checking blood pressure levels, we're checking target organ damage. So we're doing echo 6 to 12 months in. We're also checking renal function. So periodic electrolyte this is for those on AC inhibitors or diuretics. Yeah.
Subsequent uses. Important to
Yes. So counseling on cardiovascular risk factors and adherence to new lifestyle. Because the lifestyle has its own non-pharmacological parts in the treatment of
so it's important to continue the lifestyle that has started. Don't fall back.
Yeah. So good. We've talked about essential hypertension. And we're getting close to the end of our presentation today. We appreciate our listeners for following us. We've spent about 55 minutes thereabout. So management of secondary hypertension, simple, based on etiology. So that's why we must look for the secondary causes. It's until we've excluded them before we say essential hypertension. So it's wrong practice to find an adolescent, let's say 15-year-old with elevated blood pressure, and day one in clinic you find blood pressure is 148, antihypertensive starts, and that is all. So we need to know why. So about 90% of secondary hypertension they are caused by chronic kidney disease with vascular disease or coarctation of the aorta, right? So remaining 10% are other diseases. So it's good that we look for coarctation of the aorta, we look for renal ischemia, because correctable hypertension in children are those who have either renal vascular or coarctation, because you can stent them, it becomes normal, right? So it's good to be able to pick them. So renal vascular.
So reversible hypertension is due to any lesion that impairs blood flow to a part or all one of the kidneys. So any impairment of blood flow to the kidneys accounts for radiovascular hypertension. And this accounts for 3 to 10% of children with hypertension generally.
Yeah.
So as we mentioned earlier when we were discussing specialized testing, it's important to do a Doppler ultrasound, CT angiography, MRI angiography, and then renal arteriography, children if you're considering the radiovascular cause for the hypertension.
Yeah.
So while awaiting definitive treatment, as we mentioned earlier, vascular and coarctation of aorta is one of the reversible and treatable causes of hypertension. So although while waiting, we can't just leave the child, like we can institute pharmacological treatment to pending when definitive treatment and surgery will be carried out.
Yeah.
So as we mentioned earlier, ACE inhibitors are renal protecting. So in this case, that will be our go-to drug to start with children with vascular hypertension. Also, calcium channel blockers.
But while on ACE inhibitors, we must monitor renal. So the renal filtration rate, it may drop, so we monitor it. So but calcium channel blockers are also
another option. Especially those who have less impairment. So and then definitive treatment is by revascularization of the stenosis. Bypass graft.
Yes, so it can be surgical or endovascular. So and the vascular skill increasing, so one does not need to do open surgery. So coarctation of aorta, we chose to talk about the renovascular and the coarctation of aorta because there are things that we can do, use surgical or interventional means to cure. Right. So 4 to 8% of all cases of congenital heart. So every congenital heart disease, I propose that whoever does it should rule out, look out for coarctation of aorta and say no coarctation of aorta, because you can imagine 4 to 8% of all of them, right? So, but it's even higher among children with Turner syndrome. So all children with Turner syndrome should have an echo done, and the echo should tell us about the status of the descending aorta, right? So it's commoner in males. Like we said, coarctation is usually juxta ductal. So these images we have here, this is said to be the population. This is the main pulmonary artery that branches to right and left, right? And then there is this ductus arteriosus at the point where the pulmonary trunk bifurcates into left and right. And it goes to the inferior surface of the aorta at the junction of the arc of the aorta and where the descending aorta commences, right? So with a patent ductus arteriosus there, the caliber of the descending aorta is not necessarily altered, although the architecture is kinked, right? But if the ductus arteriosus is closed, then that's, yeah, there's significant narrowing at that point. Yeah, so it's important to hear that. Good. So coarctation of aorta, we watch children with coarctation of aorta regularly for hypertension in the arm. Yeah. So this is where 4-leaf blood pressure measurement comes from. So if the systolic blood pressure is less in the lower limbs, you suspect it because we know that peripheral amplification should cause the larger elevate. Okay, so treatment is balloon angioplasty and vascular stenting, or open surgery where you have to do a resection and then yeah. So technically, we've talked about treatment of hypertension, essential and secondary, right? So this technically brings us to the end of the presentation, but we have a puzzle for our listeners. We have this puzzle, and if I have to debate with my co-presenter at this point, I made proposing the motion that states that childhood hypertension is one of the most neglected aspects of pediatric care in Nigeria. So I will argue for this, while she may argue against it. All right, good, fine, yeah. So what are the take-home messages?
Proper blood measurement. I think at the end of this webinar, you know how important it is to properly measure blood pressure, to use the right tool in assessing blood pressure, not generalizing like adults for every child for each age and gender. You know how important it is to measure blood pressure and how height measurement is necessary.
Yeah.
Measurement of blood pressure, whether assessing the BMI and just generally taking blood pressure to get the height.
So there is this at-risk population in pediatrics. Babies who were less than 32 weeks gestation, babies yeah.
So it's really important to survey early BP surveillance so we can catch hypertension, early onset of endocrine damage in this patient.
Also, rule out vascular and perfusion of related hypertension in children. Don't just start treating. You could treat, depend on the medication, but then we want to rule out these two causes of treating. Now, I may say that one of the problems people who care for children have is that they don't have these charts, right? So to take care of that is why we are delivering these charts and these slides, which will be distributed to all listeners. So treatment goals is for childhood hypertension. If it's the straightforward one, primary no complication is less than 90%. But once there is any complication, good. So thank you all for joining us in this presentation. We do know if we have questions. Yeah, if we have questions, we can look at them. Okay. Mhm. Okay, so what are the basic minimum investigations needed in the evaluation of pediatric hypertension? So we have said that there is a general and then there's a specialized, right? So the general we talked about urinalysis. I mean, every child should have a urinalysis. Yeah, general function.
Lipid profile, which all these things are not commonly routine, but they should be routine for assessing child hypertension.
Yeah, it's okay. So, sorry, there were instances where we could not hear us, but I think we got it now. All right, the slides will be sent to everybody who participated. It's all right. So thank you all. This brings us to the close of our webinar session today. We shall have the Giving Hospital will also have another webinar in the next 2 weeks, which we broadcasted from Cardio Care, right? But Trust Hospital will have monthly webinars, presentation sessions. Thank you all.